what I'm going to tell you a little bit about how or when do you refer a patient with aortic stenosis or mitral regurgitation or mitral stenosis for either surgery or minimally invasive valve therapies. So this is of course new. This is a newer version. So I just want to show you first a case. So this is a 75-year-old gentleman, 75, relatively young, healthy, who comes in with no prior cardiac history, and he is short of breath when he exerts. So this is the most common presentation of aortic stenosis, that patient comes with shortness of breath when you exert. And no lightheadedness, blood pressure is good, and if you hear there is no second heart sound, there is a systolic murmur, it's a late peaking systolic murmur, and this is typical for severe aortic stenosis. What do we do for this severe aortic stenosis? So first thing is to do an echocardiogram, confirm that this is aortic stenosis, measure the gradient. If the valve area is less than 0.7, 0.1, then you can say that less than 0.7 is typically a severe aortic stenosis, mean gradient more than 40, serious aortic stenosis. So what is done? So most commonly, these patients require a sternotomy. I just brought some pictures so you understand that what really the aortic stenosis treatment looks like when you do open heart surgery. So this is the open heart surgery, aortic stenosis. If you look at after you open the chest, what you have to do is this is the clamp on the aortic, you see the little forceps. So this is the clamp on the aorta, and then patient goes on pump. So now the the pump is pumping the blood and oxygenating the blood, so you are on a heart-lung machine. And at that point, there are 6 steps to replacing the valve. So first step is to see the valve and cut out the old valve. That is the first panel. Then you to cut the valve out. Once you cut the valve out, you measure the annulus appropriately. Once you measure the annulus, then you sew the new valve, and this valve can be bioprosthetic valve or a mechanical valve. And the valve is sewed in place, and then made sure that the valve is not leaking around it, and then you close the chest. Can be done with both ways. Can be done with a full sternotomy or a mini sternotomy, as you can see in these 2 patients. What is the other alternative? So this is now an 88-year-old gentleman, of course a little bit older than 75, 88-year-old guy, who is again complaining of shortness of breath. As you see, the ejection fraction is normal. The aortic valve area is 0.7. Coronary arteries are good. Creatinine is okay. Coronary arteries have moderate disease. So until the disease is more than 70-80%, I typically say that until it's more than your age, you should not worry about it. So if you're 80 years of age and if you're 70% lesion, you probably can leave it alone. So this is, and has a tortuous iliac arteries. What do we do these days? So these days, this is from Cleveland Clinic, we would say that we would all sit down, discuss with the heart team. So we have a team of cardiologists, cardiac surgeons, sit down together, say that this patient really needs some treatment or not, and what are the treatments that are needed. And we have a surgeon and cardiologist work very closely together. This is our operating room. It looks big. It is very big. And this particular room is a huge room, but as you can see, not many people there. It is not that we have 25 people. It is just that a cardiologist, a cardiac surgeon, echo technician, 1 nurse. So it is a lean operation, but it's a very large room. It's a room size of this stage. And it has a capability within 3 minutes to go on pump, or we can do transcatheter aortic valve replacement. So this is very unique. It's a hybrid room where all these things are possible. No general anesthesia, no Swan-Ganz, no arterial line, no catheters. So this procedure is done awake while you're talking to the patient. We go in the groin and we put a few small tubes. As you can see, there are a few tubes, and these days we just put everything in one groin. So we don't even go in 2 groins, just one groin. We put all the tubes in one groin, and we put a little filter in the carotid artery so that you do not have stroke while you do this procedure. And this is a little filter, and this filter, as you can see on the arrows there, the filter goes in the innominate and the left carotid artery. So it goes from the radial artery, very simple. Within 2 minutes, we put the filter. And now this is the valve. So this is again while talking to the patient. Patient is talking, heart is beating, and you inflate the valve. You put the valve exactly in certain spot. You put the valve such a way that the valve is replacing the old valve. Old valve is pushed to the side, the new valve comes in place, and the new valve is functioning. We have a biplane lab. And after the valve is replaced, we check the echocardiogram, make sure that there is no leak around the valve. We check the hemodynamics. Hemodynamics meaning the pressure inside the left ventricle and outside the left ventricle across the aortic valve. There is no gradient. LV and diastolic pressure is good. Every patient, we check these things. And then we do an aortogram. Then we check the aortogram. There are certain ways that these are little complicated things, but where the dicrotic knot should be. We did a lot of research on this. So there are several papers we published to look at different types of hemodynamic parameters. And then we check the leak of the valve. If there is no leaking of the valve, we are good. Then we just remove the pace. So there is a temporary pacemaker. We pace the heart at a fast rate so that the valve is not ejected. So we use the pacemaker, pace the atrium, make sure that the atrium can conduct the heartbeats through the AV node into the ventricle. And if it conducts well, then we are done. We discharge the patient the next day. And we, of course, do a picture from the groin from the same side because we already have two sheets on the same side. So we do a picture. All of these things, this is the timeline. So this is not rushing or anything like that, just a usual procedure. And it took 28 minutes to replace the aortic valve. Now, it is like a miracle that you can replace an aortic valve in a patient who is wide awake, talking to them, replace the valve, and you can go home the next day. This is 2018. We just finished 2019. So this is 2018. We did 500. This is in Cleveland Clinic. We did 500 aortic valve replacements, 60% high risk, 40% intermediate risk, 90% conscious sedation. 1% died at 15 days because the Jehovah's Witness, there's some religious beliefs that they don't want to take blood transfusion, and she had a GI bleed and she didn't want to take blood transfusion. 1 stroke out of 500 patients, and 1% or less people with a significant aortic regurgitation. New permanent pacemaker, 5%. So this is last year. This year we did 700 aortic valve replacements, 700, without a single mortality and 1 stroke. So, and this year our pacemaker rate is 2%. There are several trials. These are all published in New England Journal of Medicine to compare surgery versus transcatheter aortic valve replacement. And one of the most important one, that is the low-risk trial. 1,000 patients randomized either surgery or not. And if you can see, the red line is surgery, meaning that the outcomes were a little bit worse for surgery compared to transcatheter aortic valve replacement, or at least as good as the transcatheter aortic valve replacement. So this procedure, although extremely simple, of course is costly, is extremely well tolerated by the patient and works very well in the patients. And if you look at other smaller outcomes, like left bundle branch block, bleeding, AKI, means renal insufficiency, all of those were better with transcatheter aortic valve replacement compared to surgery. So what is the goal? What is the correct thinking? So what we say nowadays is that we do surgery. In the past, we used to say if you are a low-risk surgical candidate, you should have surgery. So this is the initial way of how we thought about it. Nowadays, we say that if you are a low-risk candidate for TAVR, meaning non-surgical aortic valve replacement, you should have TAVR first. If you are a high risk for TAVR, so what are the high risks? So there are certain things that, if you have a bicuspid valve, if you have a lot of mitral regurgitation, coronary artery disease, your valve is so calcified that there is a risk of annular rupture, the annular size is different, the coronary arteries are too close. So there are some anatomical reasons where aortic valve replacement is not good with TAVR. Then we say that you do surgery. So yes, we do consider TAVR for every patient, consider TAVR for all, and if not a good TAVR candidate, then consider surgery, as I said. How about the mitral valve? So again, last year, there were 2 very important papers published in New England Journal of Medicine for the mitral valve. And both all of these trials we have been part of, and I've been on the steering committee of all these major trials. As you see here, this is the transcatheter mitral valve replacement. So what it is done, so this is a mitral valve repair. So this is a small clip. If the valve is leaking, you can put a clip on the mitral valve. And the clip is very easy. So you go from the groin, you do a transeptal puncture. This is the clip going in from the transeptal axis. the clip will turn. You can turn the clip with just dialing the dial, and clip can open. You will see the clip opening. And once the clip, you can adjust the clip where it is. You see the mitral valve beating underneath. When the clip opens, you can advance the clip across the mitral valve. That's the leak. The blue part is the leaking because the valve is not coming close to each other. Now you open the clip, you grab the leaflets, lower the grippers, and close the clip. So you can reduce the mitral regurgitation. So very simple procedure, and it is extremely safe. So here is the actual patient. So this is a patient who has, as you can see, very significant mitral regurgitation. The leaflets don't come close to each other. You can see that the leaflets are not coming close to each other. And in this patient, the valve is leaking. This is a short axis view. The valve is leaking tremendously. And here we place 2 clips side by side, just from the groin. This is done with general anesthesia. The only reason is that we need a TEE, and it takes about hour and a half. So 2 clips are placed. And once the 2 clips are placed, as you can see, there is no leak across the mitral valve. So the mitral valve is no longer leaking as the clips are placed across the valve. And if you look at the MITRA FR and the COAPT, there are 2 trials, but I'll just focus on the COAPT trial. MITRA FR was a trial done in France. COAPT was a trial done mostly in the United States. There was significant difference in mortality and rehospitalization. You had to treat only 6 patients to save 1 hospitalization and 3 patients to save 1 death. So it is again an extremely useful thing. Which patient should we send to MitraClip? So if you have a bad ejection fraction, if a patient with a poor ejection fraction, mitral valve is leaking, then the best thing to do is to understand that if the EF is very poor and leak is not as much, then don't send them patient to MitraClip. But if the EF is 45, 30%, 25, 30%, and your mitral regurgitation is 4+, very severe mitral regurgitation, then these patients are the right patients for sending to things. We also have other procedures. So this is a procedure, very simple again, going from the jugular vein, and you can put a ring around the mitral valve. So this is the Carillon device. So this is a ring that goes around the mitral valve just like that, putting it through the coronary sinus. And there are 2 other devices that are available. So one is the replacement of the mitral valve, again percutaneously. So this is the valve that is available. And these are all under clinical investigation. Or there is another valve that is available that goes through opening the chest a little bit, going from the apex, again replacing the valve in a beating heart. It's a video which is, again, I have 2 minutes, so I can just show you for a minute. But this is the valve that goes right from the apex, and just like that, putting a wire from the apex and suturing the valve to the apex. In the interest of time, I'll just quit that. So what is the recommendation? So recommendation is that if you have a primary mitral valve regurgitation and if you're short of breath, so if you are super high risk, meaning that if you have a prolapse of the mitral valve, primary meaning that there is a problem with the mitral valve. It's not the problem of the ventricle or the atrium, but it's the problem of the mitral valve. So that is called primary mitral regurgitation. Primary meaning that the valve is prolapsing, valve is damaged, and in those situations, you can use MitraClip very effectively, relatively easy procedure, and in the high-risk patients, this is currently the standard of care. If you have a low-risk patient, then mitral valve repair done with a good surgeon is obviously a better choice. If you have a mitral regurgitation with a poor ejection fraction, meaning that the heart is damaged, muscle is damaged, you are short of breath, severe mitral regurgitation, because the mitral valve is okay, but the heart is dilated, or the annulus is dilated, so valve cannot close properly. This situation, MitraClip is a good option after using guideline-directed medical therapy. So after you have used the ACE inhibitors, ARNIs, diuretics, and proper afterload reduction, if they still are symptomatic, then you can refer them for MitraClip. If you have mitral stenosis and mitral regurgitation, then mitral valve replacement is the best option. That part is a little bit investigational in the sense that there are at least 10 different types of mitral valves currently available, but they are not FDA approved for mitral valve replacement yet. So we are doing all of those, but we are doing it under clinical investigation at this time. So thank you for your attention.